Hey, y'all, another fun week. A lot of stuff happening. We have a guest this week with us.
It's the third Hardle brother.
Brian Smith again.
The honorary, actually the fourth Hardle brother. The
first
honorary
time, right?
Hardle brother.
I just had to give him, harass him a little bit. Cause
Got it wrong
like,
the past 3 episodes.
he's like, I'm not a guest. I'm a recurring, I'm a
Character.
staple. I'm a staple. I'm a character to the podcast.
He's got a SAG card.
So Brian is now tenured. I can't call him a guest anymore. But anyways, welcome back. Like always, there's just so much to talk about. We actually were having a discussion prior to hitting the go button about which of all these topics should we actually narrow it down to and cover this week. And so we're going to be, covering 3 or 4 different things if we can during this episode. But kicking us off, what do you think? We're going to be talking about Inflation Reduction Act. We think that there's a big, a lot of misinformation out there, and I hate using that word, misinformation, thinking about all the COVID stuff, but misinformation, but there's a lot of lack of understanding about how the Inflation Reduction Act is going to affect PDP and benefit structure this coming AEP. That's what we really want to talk about. But before we really dig into it, we also want to talk about maybe some ACA changes that are happening, as well as some regulatory stuff that's happening as well.
Yeah, we've got, Viserys from Game of what's the eunuch's name? From Game of Thrones that has the little birds out that whisper. Varys,
yeah.
Varys. All our birdies. We've had birdies coming to us every day with information, high level stuff, and then we've been in some pretty intense meetings with carriers and big partners, and we don't want to really, leak out anything or kind of give away some sources, but there's a lot of stuff going on in the industry. So maybe let's talk real briefly about ACA and kind of some of the positive changes that we see coming down the pipe.
I would lead with that and say that we've been in a lot of conversations with key decision makers at carriers on the ACA side over the past few weeks. We've also been in conversations with vendors and technology providers and other folks. And essentially, I really do think that we're at a spot in time where I think everybody gets it, that it is the buck stops here. We all need to do our part collectively as an industry. And either we are going to, at some point, work together and rein some of the fraud in and the bad practices and the bad actors, and we're going to come up with a market solution, or else we're really going to get, CMS, intervening and
daddy government stepping in
with their solution, which ultimately I don't think anybody necessarily wants. So I think it's taken a lot of time and pain and conversation and data and all sorts of things to get to this point in time where everybody's essentially at the table. But I really do think that buy-in is there from all of the carrier partners, from the technology partners, from everybody. And I think the desire is there for them to come up with these solutions to the problem right now.
Yeah, there's also been some shots across the bow with some of these lawsuits against some of these really bad actors. We're hearing carriers, some of our carrier partners are issuing terminations to some of these bad actors out there in the industry. So there's some correction going on, because you have this dichotomy of a lot of these carriers are still operating in the ACA space, and they're seeing what's going on the Medicare side of things with all of this onerous regulations and all of these rule changes and compensatory things that are going on. And it's like, oh man, we don't want that to happen. Let's clean up the act on the ACA side of things. And you would think that they'd be able to, whatever they're doing with Medicare, just apply it to ACA or vice versa. But the reality is they can't, because the backbone of the infrastructure of the way that the systems are set up, Medicare is, essentially there's a system of Medicare and processes and a database that's mastered and ran by the government. Like you can log into CMS and somebody's MBI functions like their social security of their healthcare, but you don't have that on the ACA side of things. So there's not like a central source or repository for all of this application management to go through, and so it's a little bit messier.
There's no source of truth, right?
Yeah, there's no one backstop in the ACA industry where, if Brian has a policy where this carrier knows, well, this is the slot that ACA is occupying, that insurance policy is occupying, and there can only be one policy or one person accessing that at the time. Like you have the on the Medicare side of thing with their MBI, of course, we know you can only be, CMS administrates that, you can only be enrolled in one plan at a time. But on the ACA side, it's much more convoluted. And so you have to have the free market try to find solutions to fix that problem.
Yeah, and I think we're closer to that. And so I think just my call out to everybody listening is we are getting closer and closer to real solutions to the problem. I think we're seeing steps in the right direction from terminations, from lawsuits, from regulators, from insurance commissioners. I think we've already started to see the activity and behavior. And I think the actual full-scale solution to a lot of that is going to come to fruition here in the next couple of weeks and definitely by this fall. So it's a couple things. Number one, if you're listening and you're a regulator, I would just say, hey, chill out. The private market is coming up with those solutions. Number two, if you're a carrier, I would encourage you to opt into some of these solutions that are being created because candidly, some of the carriers are taking the position to say, look, we're just going to very heavily now actually look into DOI complaints and other, complaints that come our way, and we're actually going to investigate them. My counter to that is only a very small percentage of actual fraud and, bad behavior that occurs in the marketplace actually results in a member making a complaint and escalating that to the authorities.
Right.
Maybe 3-5% of the actual bad behavior gets escalated. So if your position is we're going to take very seriously all the allegations that are presented to us, well, what about all the other cases, the 90-something% that never makes it to your desk, so to speak? What about all that? And so I think that's my counter to carriers listening is please, please, please opt into the solutions that are coming to the marketplace that will empower you and allow you to create solutions to all this. And then to the brokers and the agents and the agencies out there functioning in the space, if you haven't fixed your selling practices and are not, being a good actor, now's your time and now's your last kind of moment before this next sales cycle this fall. Between now and September is when, if you have not been doing things the right way, please get your house in order, so to speak, change, modify your P&Ps, do things the right way, because if you don't, I just don't see a big runway for you to exist.
Right, and regulation at that point would be inevitable.
Right.
Yeah, so parlaying that into, in some of these same conversations, the same theme that's coming up on the ACA and the Medicare side of things pretty much universally is we're seeing CMS cracking down on some technological access points, both on the ACA side and on the CMS side. And that's probably, due to us.
Yeah, talk about a grenade and everything, right? I mean, this year, what a CF of a year. And I'm not going to give you the definition of a CF. It's FUBAR. It's I could keep going on about all the acronyms, but what a year we're all living in, to where even going back to the Change Health hack happening earlier, look, all of us trying to function in the industry and trying to do a good job of seeing what kind of a product does this person qualify for, whether, again, we had the Change Health hack, and now we're having other situations where now, to your point, I think CMS is in a position where, and again, going back on the ACA side even, so many bad actors with EDEs and access to information, to where I think now we're observing that in the last few months, CMS has taken the tone of like, hang on, things have gotten out of hand. Things are not really reined in. So we're going to take a few steps backwards and we're going to shut off access to information and certain technologies. That's what we've seen or experienced. We've been talking about Mike and Little Birdies. We've been talking to different carriers and, sponsorship to Marks Access and, other technological systems and things that carriers sponsor and, access to data and information. A lot of those things are kind of being shut down at the moment.
Yep.
And to try to operate in the space, in the technology world that we live in, and trying to do business in a 2024 way is really challenging when we're going back in time 10 years right now.
Yeah, it's kind of a throw the baby out with the bathwater approach right now that CMS is taking, where they don't really have either the knowledge, the insight as to what these API integrations or data access points are doing. And so it's like, well, let's just clamp down and shut down everything. Right. Let's kill off all the access points right now. And then we can kind of go through and try to restore some of these things. But all that does is it's making a lot of these things more difficult. A lot of these tools, you mentioned the change hack that's caused all this turmoil. You know, we're hearing that they've had to completely, we know they've had to rebuild that entire tool because it was so obviously vulnerable. But
let's put it this way. I'm not an IT expert, just so everybody listening to this, I don't need to be attacked by a mob of IT nerds. You're all smarter than me. But I do understand that with the hack, they probably embedded ransomware onto, after they paid the hostage fee to release it, they can't just fire it back up. They've had to essentially rebuild everything onto completely different servers.
Correct. New servers.
In order to bring it back up and active again, because if they were just fire it back up, they'd
be vulnerable. Yep.
They probably embedded some of that ransomware to was just there, and it would be vulnerable again.
Yeah. So that we're hearing that they're hoping that that's semi-functional sometime before annual enrollment, which again is not
just in time.
Not great. So everyone's gonna.
Hey, our target line is September 30th.
Well. Meanwhile, and this is kind of a side quest topic, but you have the whole SEPs that are becoming a hot button issue with the duals for next year as to who and when is going to be able to make those enrollments, and who has according to CMS, who has the FIDs, the FID fully integrated duals, and the HIDs.
Yep.
And most states don't have those.
You know who you are listening to this podcast. We had a conversation earlier today about that, where when you look at the 50 states, not all 50 states have HIDs and FIDs. So then you leave this very gray area of interpretation going like, well, which states will have this SEP into which plans, because not all the states are HIDs and FIDs.
Yeah, what's an integrated one? So which plans, which carriers, which states are going to be able to use these SEPs for this next year? So there's still, again, a lot of murkiness. That's just a
lot of ambiguity.
It looked like an actual positive in the agent space, being able to go back to monthly SEP allowances, but away from the quarterly.
So again, you have no tools to verify these increasingly diversified eligibility. You have much ambiguity as to if and when, who can use these SEPs for 2025 and going forward.
And Mike, what's my source of truth? I'm an agent. I'm trying to sell this person. How do I know if they're a partial dual or a full dual?
Have them find their Medicaid card and their award
let me call
letter.
Betsy that works at a carrier and sit on the phone for 40 minutes and figure out if they tell me the right information or not.
They're laying all those people off because they got to cut costs.
Yeah. That's right.
Yeah.
That's right.
So,
because we can't staff up more humans to do the work because we got a cut in our reimbursement.
And then everyone uses different acronyms for the same level of Medicaid. So you can't get the source of truth from the Department of Workforce Services either.
And not only that, every state has a different eligibility level, like we're talking about, right? Like FBDE or QMB or is it a QMB plus or better
QWBI
or whatever?
So add that to the list of things that we all, as the industry, need clarification on from
by the way,
CMS.
If you're a new agent listening to this podcast, it's really easy. The water's warm. Come get in. It's friendly. It's very fun.
Get in the boat.
Come join the party. It's a lot of fun right now.
It's one of those things where it's like all these CMS put out, all these action items and all these things that they want to shove through, and then they're like, oh wait, each one of those things caused another chain reaction of 10 more things that need clarification and are ambiguous, and it's just everything is so jammed up right now. It's hilarious. And
to add to that, as I was just joking about new agents, come jump on in. The water's great. It's warm. Come sell here. Am I even supposed to be doing that as an FMO right now? Do I get paid to recruit agents and develop them and train them and teach them all these very sophisticated things and empower them to coach and educate consumers and teach them about a plan that might be? Do we get paid for those services yet? Do we even know?
From a few forward-thinking carriers.
You have all these things going on, and then you have these entities that are going, do we even need brokers? Are brokers, are agents and FMOs even valuable? What purpose do they serve? And we're sitting here going, wow, you don't even know what you don't know. You have no idea the landscape, and imagine trying to be a consumer out there. So let's kind of
and even transitioning now into what we're going to talk about, the Inflation Reduction Act, which is funny because
do you want to real briefly talk about the North Dakota State Department of Insurance?
I do. Hey,
mention it.
Yeah, shout out to that. I always give credit where credit's due. It was Sam Melman that at NCD that kind of brought this up and mentioned it, and so shout out to Sam. I'm still hoping you're a guest here very soon, but. anyways, he posted about it the other day, and how the North Dakota Insurance Commissioner actually sent a C&D, a cease and desist, to 3 different lead marketing companies that were actually doing direct mail. So I did request and got from him the actual cease and desist orders. But essentially, yeah, the commissioner sent it to 3 lead gen companies that were doing direct mail. And the whole point of it was that they were not, based on some of their state code, they weren't properly authorized to be generating those types of leads because they're not licensed insurance agents or like fiduciaries in the state. And so they basically cited the state codes and said, you're done. You can't advertise to consumers anymore. So essentially, I loved it. I know the 3 entities that got the cease and desists. And yeah, we'll see.
Was that only for them to operate in North Dakota, though? To all,
the insurance
all 27 Medicare beneficiaries in Buffalo.
Were they based out of North Dakota, or are these national?
No, these are national advertisers that had sent campaigns to North Dakota.
Oh, okay.
Now, of course, the North Dakota Insurance Commissioner only has authority to do that within their state, right?
Correct.
But they did say, hey,
which is the least amount of Medicare beneficiaries.
But they at least did say, hey, around these parts, like, you're not going to be sending these bait switch, type of advertisements, misleading, pieces, to our, residents here in our state with these bad practices. And so the question that Sam posted, and I would echo, is, yes, are we going to see more commissioners? Are we going to see the NAIC? Are we going to see more insurance commissioners stepping in to say, hey, let's start reading through our statutes and our codes that we have within the state, and do we have anything in place that can prohibit marketers from being able to just market to the state? Because again, going back to, look, if you're an agent or an agency and you have an NPN, you have to go through certifications every single year to know what you cannot do. You are regulated. You have all these authorities who tell you, again, good practices, bad practices. When you're a marketing company, you have none of that. It is the wild, wild west, and you do whatever you want. And so can we ever get to a place to where they can say, you're not authorized, here's a cease and desist, you can't generate leads or marketing revenue off of these products because you're not following these guidelines?
Well, that entity doesn't care whether or not they're compliant, because guess who's on the hook for using their services?
The agent that buys.
The agent, absolutely, 100%.
Yep, and if any of you regulators out there actually do want, an example, somebody to hang or make an example out of, there are all sorts of lead vendors. You want to talk about the seedy underbelly of our industry. It's those lead generators that have been operating with impunity, where that are operating outside of the scope. There's been so much money in the generation of leads, almost to the point where there's more money in the selling in that
than the selling of an insurance policy.
And that's where there's got to be some cracking down for sure. Which the funny thing about all this stuff we're talking about repeatedly over the past couple of months is that's where this all started from, was how to fix those type of problems. And then it's evolved into creating a whole subset of issues and focusing on fixing the wrong set of issues.
I think this could be a whole other podcast in itself.
So I would say that. So if anybody's listening that is in any sort of a compliance or regulatory environment, if I can point you in the right direction, I think a very good direction would be starting to talk to state insurance commissioners and having them look at their own statutes and laws, and essentially having them send cease and desist to lead generation companies, and at least the larger ones. And that would actually be something that has some teeth to it, and actually would be a way to start slow rolling. And if you can kind of take away the revenue and some of the monetization of those lead aggregators, then you're going to start to make a big impact.
Well, that was initially the CMS initial stuff in the letters, was to address some of the bad actor lead generation stuff, but that's kind of all.
But none of the policies that they put into place in the call.
But it was only geared toward agents, though.
Or they just closed down one little window and they moved it through the other window, where they were initially talking about changing some of the lead gen stuff, where they do have to be licensed entities. They do have to have contracts with these carriers. They can't be these third party, wild, wild west actors that don't have to follow any of these rules.
Well, shout out to one of the lead vendor partners that we've been working with. You know who you are. They actually came to us asking for compliance regs and like, hey, how can we make our pieces more compliant so agents will use them?
Yeah.
Because agents started pulling back, saying, hey, I can't do your stuff anymore.
Right.
Well, we better kind of get into the meat and potatoes of what we wanted to talk about, which was...
This is the big one, the Inflation Reduction Act. I think the name is a little counterintuitive because,
It doesn't say anything about Medicare. It doesn't say anything about Part D, but it's very much included.
I'm going to be... The irony is you think like, oh, yeah, we're the Inflation Reduction Act. We're, going to do some measures to make things more... We're going to counteract inflation and rising costs, and we're going to curb things and make them more affordable. That's going to be... And I think we're going to dig into the crux of the Inflation Reduction Act and the Part D. It's going to be beneficial to the few, but a lot more expensive for the many.
Shifting costs around like we're seeing. Shifting costs from one group of people to another.
And what we've really wanted to kind of dive into this topic is that we're really not that far away. I mean, certifications start next week, and brokers are going to have to start becoming very familiarized with everything in here.
Yes.
And there's very little knowledge base from what we've been able to determine from the broker community. It's scary to know that the broker community needs to now go out and educate consumers, and they themselves know very little.
I'm terrified to see the amount of failures coming back from AHIP this year because agents are just going to try to click through as fast as they can like they always do. This is the time to actually dig in, do your due diligence, and read each slide because AHIP's been working for 2 years now to update this stuff.
And I'm going to also, while we have our moment in time, we're talking about certifications, everything, I'm going to go ahead and give my shot across the bow to Aetna and say, I'm going to take my shot and say, you give me a good reason as to why you're not accepting the NABIB certification for agents. I really don't like the fact that every single other carrier, including United Healthcare and Humana and everybody else, is accepting the NABIB certification for brokers every year, and you're the only carrier that's accepting just AHIP. It's preventing agents from having choice on, again, which platform they're using to do their certifications. Again, I thought we established years and years and years ago that monopolies weren't good and that having only one option is not a good thing. So why is it that for certifications, we have to and we're forced to do only AHIP for our certifications?
Well, and United has their like-kind certification themselves, where they've created their own thing that's commensurate with even doing AHIP. So,
but my problem I have with Aetna is if they would then create at least their own track and say, fine, I'm going to take NAHU and I'll do the NABIB, NABIB certification, and then I will then go and take my Aetna track for my certification. Good, I'm good to go.
Yep.
But they don't have that.
Yeah. So I have one hypothesis about, since AHIP's coming out next week, and we'll see how this prediction ages. I actually don't think there's going to be that many. You would think this year there would be more changes to AHIP as far as slides and things. I think there's going to be actually very few. That it's because even AHIP and the training and the rules and the regulatory stuff doesn't really know how to firmly bake in.
You don't think they're going to get in the weeds?
No, I think there's going to be a few things that we know for sure are going to be changing, but as far as like HR, maybe like HRAs going away and the agent comp, anything that's like very firmly solidified at this point, but I don't think there's enough things that have been hard baked in enough to then have updated the curriculum. I think a lot of it's going to be, creeping out after the fact.
That's a good point.
Answer C is going to be answer A again. Mary should wait the 48 hours before.
Yeah.
You may go ahead and call them. Yeah. It's a good point, but it still doesn't change the fact that the Inflation Reduction Act has been in place for years now. It's just now transitioning to what's going to happen in 2025.
Well, implementation is about to occur. And
it passed in 2022?
Yep.
Yeah, everyone knew like a few years back that, oh yeah, great, my insulin is now going to be capped at $35.
Mm-hmm. Yes.
They thought that was the end of it. There's no other regulation coming down the pipe, and that is so not true. This goes all the way through 2029. There's going to be new steps along the way each time for this implementation.
Yep. So to set the table, the way that this legislation, and this is separate and aside from a lot of these other call letter and a lot of these other regulatory things, but it's been clarified and there's been some updates to how this will apply, and now we have a little bit more clarity to this. But essentially, the Inflation Reduction Act is meant to affect the cost of prescription drugs for consumers on Medicare beneficiaries, and there's essentially a couple main components to it. Brian, do you want to cover the three main components to what this is going to cover?
Well, We already know that it's already transitioned for the $35 cap on insulin.
Yep. Okay, that's the one
covered
thing.
insulin. Mm-hmm. We're transitioning to a $2,000 maximum out of pocket for Medicare beneficiaries starting in 2025.
So updates, we'll talk about that new structure to the Part D.
And there is a 6% cap on how much Medicare can increase their base beneficiary premium.
Yeah, the third part I was going to say is that it's allowing carriers to be able to go negotiate prices directly with the pharmaceutical companies for the first time, right? So the big three components of this are the restructuring of the Part D formularies, the capping the medications at $35, and then what you'd said, which is
6% rule.
Yeah,
so that's very misunderstood.
What's interesting, what most people don't know, is that Medicare, who is the biggest group or consumer of medications really out there, usually in anything in the world, like wholesale or volume, or the more that you do, the more negotiating power that you have
purchasing
in a
volume,
purchasing power you have in a transaction. How counterintuitive has it been that I think on average Medicare has been paying like 106% of what even like commercial plans were paying for meds, which is so backwards, right? And that goes against, again, there's a big pharma lobby, pharma lobby too.
So we've already seen the insulin being capped at $35, and I think everybody across the board was kind of thinking that was pretty good for beneficiaries, and that was a pretty big win. But let's talk about, kind of the big meat and potatoes that's going to come to the restructuring of prescription drug plans and how it applies to agents and what we're hearing this is going to do to the industry and why you should care as agents. But the gist of it is this is forcing the carriers to restructure and cover the Medicare, the Part D, that are both built into the Medicare Advantage plans, MAPDs, and prescription drug plans. And they're changing the deductible stage. They're changing the initial coverage stages, and they're also catastrophic as well. And they're capping the troop at $2,000.
So I'm going to back up
a little
bit on that to when I was a selling agent back in the day, when I walked uphill both ways with gunny sacks around my feet and everything was challenging. But, going back to even, Obama administration and all those, and if you've been an agent now and selling for a lot of years, we've been talking about the donut hole closing and the coverage gap. But just understand that, like, every administration that's in has maybe a different tone, different objectives, and it is somewhat of a moving target. And so, like when I was back selling, the donut hole was going to close by 2020, right? Mm-hmm. That was like really what was going to be happening. And then, of course, as every administration changes, the rules of the game kind of change along with it, just to kind of follow with us. So now we have to kind of exist in the environment that we're in right now. And so understand that with the why don't you just outlay it a little bit for us, Brian, like what's going to be changing from how things were in this year and the prior year and how things are going to be under the Inflation Reduction Act with Part D.
Well, to Mike's point, I think that AHIP, you're right, may be more service level and just kind of stop it at the $2,000 max out of pocket. That's what most agents are aware of, that your clients are going to not have any cost share after $2,000 max out of pocket.
So today, when a client has $27,000 in drug costs, right? How does it work with cost sharing? You have your deductible phase, right? You have your initial coverage phase. Then you have your catastrophic phase,
Catastrophic is
the last
deductible.
Right? So you go deductible, initial coverage, the
donut hole,
or whatever you call
basically, where you're still,
and then you have your catastrophic, and those are the four phases. And the cost sharing right now is to where if you're doing that, obviously the consumer is shouldering a lot of that cost, right?
So moving forward into 2025, once the beneficiary hits a maximum amount of pocket of $2,000, any way, shape, or form, obviously it doesn't include the premium that they may pay for their Part D plan, right?
Well, here's the easy breakdown. I'll show this. This is what CMS put out in a very easy to understand.
It's not easy at all.
I'm like, what the hell is that? Like, that's CMS's official pie chart breakdown.
They need to hire a better graphic designer.
I know. I'm like, that looks like my toddler made that on his.
I have a better one there, but the key indicator is that the carrier is going to be on the hook for everything for 60% of all medication costs after that $2,000 max.
Right.
And do you think they're happy about that? Absolutely not. They're going to try to recoup those dollars elsewhere. And that's what's going to kind of change the landscape of Medicare Advantage moving forward. Not to mention,
Part D standalone.
Part D standalone.
So they're shifting costs from the consumer a little bit more, and the breakdown. And if you really want to dig in the weeds, you can go look at that. Go to CMS Newsroom and look at that graphic that they put out. But there's going to be more of the lion's share of costs that are going to be falling on the carriers. Okay, so in addition to that, the $2,000 max out of pocket. Let's say someone's taking a very expensive medication and they pay their deductible and then they hit that $2,000 max. The carriers are required to have to finance or break out those payments into monthly increments instead of that consumer having to come out of pocket right there, that $2,000. So what that's going to force the carriers to do is
this is important too. This is the part of the biggest part that people need to be listening to.
So it's going to force the carriers to have to retain more money in reserves because
they're more capital.
Yep, they hold more capital because they're essentially going to have to
think of it as this
interest refinancing $2,000 times however many people across the country are hitting their max out of pockets.
So if you're a carrier, sometimes they're referred to as payers, carriers, but if you're the insurance company and now you have hundreds of thousands or millions that are insured, and out of all those people, the people who are getting into the gap or or have all these medications after that $2,000 mark, like we're mentioning, now they have to hold that capital and provide essentially interest-free financing for all the people for all their meds, which they've not had to do before. So if you're a carrier and you have, let's say, 1 million members who are going to be into that threshold, just think about all the capital that they have to set aside to account for that. Not to mention the fact that they already are running an MLRs and essentially they already have like an 85-15 ratio, and their profit margins usually are fluctuating between a 3 to 6% there. Broker commissions fall into that 15%. Everything else, their reimbursement rates are not what they would like them to be for next year. The funding environment's already ugly. And now you're telling an insurance company that, oh, hey, by the way, you're going to have to fund all these meds. So every member that you now add to your Medicare Advantage plans or your Part D plans, you have to set aside and allocate funds to fund all their meds.
Well,
after $2,000.
It's going to break down on the deductible. We all know the deductible for 2025 is $590. Right. That's been published. We know that the current average Part D premium is $55.50. That does not mean that that's not subject to more increase. So the 6% rule, it only applies to the base beneficiary premium, and that's posted as well, which is currently $34.70, right? Mm-hmm. So if you look back to 2023 to 2024, yes, that base beneficiary premium only went up 6%.
Yep.
But the average Part D premium went up 76%.
Correct.
How much, Brian?
76%.
That's it? Only 76%?
So what we're hearing, I don't know what you're hearing, Brian, but I'm hearing that standalone prescription drug prices only are most likely going to double or possibly even triple in cost this year for standalone drug prices.
For listeners, why would that be?
Well, because they got to make their money somehow, right? They got to fund these things, and they get less funding on the prescription drug plan side. They have more mechanisms to cover those costs on the Medicare Advantage side of things, and MA plans are very loath to increase premiums. They're probably always most of those will remain a zero premium plan, and you're going to see massive increases on the standalone PDP side of things. Okay,
you'll probably see no more zero copay for even generic drugs. So once you hit your deductible, and what I'm thinking is that every tier will be subject to that deductible, because that's just money that you have to pay. But that $590 will immediately go to your max out of pocket of $2,000.
Sure.
Right?
Your troop.
And then during your initial coverage phase, your member is paying 25% of the medication cost until they reach $2,000. Okay. That's your catastrophic phase. 60% is going to be covered by the carrier, and the rest by the manufacturer of that drug. So they are going to recoup that cost in many ways obviously by raising premiums, by reducing benefits, by removing drugs from formularies that they don't want to pay for. I read a study that back in between 2017 and 2020, there was probably 200 million prescriptions that were not picked up nationwide in a 3-year span. 200 million prescriptions. That we all cross that bridge with our clients that they either decide whether to pay for drugs or pay for food.
Right.
That's even, that's a horrible thing to have to happen.
Now, I'm going to kind of be forward-looking, too, to talk about this and also discuss a few other things. I want to be really as fair and not biased as I possibly can in the podcast. So I will say, who are going to be some of the winners from this, right? And who's going to benefit from this? I think some of the consumers that have significant costs that were in the catastrophic every year, who were paying exorbitant amounts of money, $8,000, $10,000, $15,000 a year in medical costs, this is going to be hugely beneficial to those people, right? But I don't know what the percentages are and what the numbers are for if you're just the average healthy person that wants a PDP and whatever else, or a Medicare Advantage, and you're fairly healthy, your costs are significantly going to be going up from this. And Absolutely. So we talk about cost shifting, and somebody has to pay somewhere, right? And so your average consumer or your healthy consumer is going to very much feel, this in their benefit structure and in their price plans.
So we all know there's a very attractive, standalone PDP out there, 50 cents or less.
Right.
Do you anticipate that will stick around?
Hold on. We'll get into that in a second. I want to bring this home for agents as to why this all should matter, right? So who's on a standalone prescription drug plan right now?
Somebody on a Medicare supplement.
Somebody on a Medicare supplement, which generally, if you had to classify these people, most of the time those are considered people who are wealthier, more affluent, or they can afford a supplement, and that's why they're on it.
Or they have a lot of health conditions, or they have to travel. Or
these day and age, that's generally who is on those. So we're already hearing, this is without major implications from the Section 1557 being applied to supplements and possible massive increases on costs there, but we're already hearing it's going to be at least a 10% across the board increase in supplement costs. 2
carriers I talked to is 25% on their increases.
So somewhere between 10 and 25% on the cost of a supplement. So let's say, someone's paying a Plan G, or you have some of these legacy outliers that have still been on their Plan F that they've been holding on to for a long time. Imagine them getting a 25% increase in their cost of their supplement this year, and then having their standalone PDP cost go up, whatever that premium is they're paying for, double or possibly triple, and then have their deductible go up as well. So what you're going to see is again, a major catalyst for people, even on supplements, that are going to be wanting or needing to shop, because they're going to get massive sticker shock there. So you're going to have that whole demographic there. And then you have, who else are on PDPs? You've got people that are on LIS, or you have, I don't know what the last statistics are, but you have 3% or so of Medicare beneficiaries who just are on MA, original Medicare only, and have some random drug plan just to satisfy the CMS requirement. So you have some of those people who are going to see their to Brian's point, their 50-cent drug plan that they've had just to sasatisfy that change.
And what is
or eliminate?
Remind me, I haven't been selling for a while. What is the benchmark at right now on the benchmark plans?
$34.70 is your.
There you go.
Your mid, yeah.
So what a guru.
Yep.
$34.70. That's the benchmark. So they file their PDP plans to be that premium amount or below, in order to have the premium completely picked up if you're on LIS.
Yes,
and that's the number that's subject to the late enrollment penalty for Part D. That's the number that's subject to the 6% increase max. So the other two parts of that premium don't apply to that.
So then on the other side, you're going to have everybody that's on a Medicare Advantage plan, and all those carriers, they're going to do whatever they can to keep those the premiums at $0, but they're going to be shifting the deductibles. We're probably going to see a lot of deductibles going all the way up to the $590
for all tiers.
Yep, for many tiers. And so you're going to have a lot of beneficiaries that are going to need to shop just based on deductible management, how that may affect if and when they're going to hit catastrophic coverage. But you're going to see a reshuffling of the board. But you're also going to see, in my opinion, a big move towards people moving off PDP onlys and back to MA, because there's going to be more financial savings there as well too. Even though MA plans are not going to be looking as sexy as they have the past couple of years, it's still going to come across most likely as a better option, especially on the drug side of things, than the alternative.
Unless you're in a rural area that just got SAR'd because, risk was high, and you're in a rural area and your MA plans just got SAR'd because, it's hard to make the economics work out and provide care for people if you're in a rural area.
I follow quite a few people on YouTube, and I catch their content, and some of it's really good, some of it's pretty funny. Mike and I spoke on one episode about those never Medicare Advantagers, right? Only pitch MedSup. And some of their content is either they're not posting right now, or it's just off, and they just don't understand the market.
Yeah.
Well, that's been an increasing landslide moving that way. But what I really think, to your point about, some of these low cost or almost no cost PDPs, we're hearing from some of our back end contacts at some of these carriers that there's going to be a lot of, they call it cross selling, right? PDP cross selling, and all carriers, all the bigs all have standalone drug plans only. And so it's going to be even more of a focus for some of these people that are on standalone drug plans to possibly shop or be, persuaded or sold into MA, because there's going to be more, it's going to be possible cost savings for them.
And one last thing to add to that too is, because let's be honest, I think people forget that these are retirees. And at the end of the day, when we start, everything's talking about from a theoretical perspective or X or Y or Z, but at the end of the day, they forget that these are retirees that a lot of them have a fixed income. Mm-hmm. And so even though you're in the middle class or upper middle class or wherever you may fall financially, they don't have the ability to just go pick up a job or earn extra income or offset it or do something else when these seniors are impacted in such a significant way. And let's say their MedSup premiums increase by 20, 25% or 30%, and their PDP prices go up by 50% or 100% or whatever they increase to. Where do you account, for that money, and how do you make it up? And you can't.
To your point, it's, a study by KFF indicated 83% of Medicare beneficiaries think the drug prices are currently unreasonable in their drug plans. 83%. This is just going to create a huge windfall, not to mention the 2.6 million people that jumped into that 50-cent drug plan this past year.
And it's all coming to a head too, and I keep bringing this up, and I'm not trying to play politics in any way, shape, or form, but you're dealing with a landscape right now where inflation is still high, no matter what they're doing with the Fed and trying to ease, and what inflation is still extremely high. These people don't have the ability to go bring in extra income or revenue. And let's be honest, COLA, from Social
Correct.
Security and the cost of living adjustment is not enough. In line with the true living expenses. And it's just creating such a bad environment for these seniors. And that's the only reason that I am okay talking about it, and not because I'm trying to poke the bear or cause any issues or anything else, but I'm a realist. We live on planet Earth. We talk to beneficiaries. We talk to agents. We train them. We're where the rubber hits the road, and we're talking to these people, and we have a good pulse on it that I think that sometimes regulators and even some people at carriers don't quite grasp.
Yeah, you hear almost every time you talk to a beneficiary, I'm on a fixed income, and people care about that, because as these costs escalate, like Dan said, their Social Security cost of living adjustments aren't going up commensurate. They're not even close. One more thing. Do we even know what the Part B premium is going to be for 2025? No, it hasn't even been announced yet, right?
Usually it is out by now.
Yeah.
And it is out usually.
And by the way, usually broker FMV is out by now too.
Yeah, and it's right. Suspiciously absent, so hopefully we don't have, a decent or even a modest increase in Part B premiums in addition to all this other stuff, because that's just going to make all these other, increasing costs come across even uglier.
But we totally forgot to touch on the prescription payment program or smoothing process. To your point
the smoothing.
About everyone being on fixed incomes in this.
Can we cover it in 5 minutes, Brian?
Yeah.
Go for it.
Okay, so smoothing process or prescription, Medicare prescription payment plan. Basically, if your drug costs are going to be, to a point where you can't afford them the first month, you can opt in, and you have to opt in. Your clients will have to actually opt in. The pharmacist will have opt-in forms for them. And once you opt into that smoothing process, then you can take all your drugs for a low monthly price of no more than $133 a month, right? Because that's 130 times 12. Mm-hmm. So the carrier will have 24 hours to respond and upload you into that system for that. They will satisfy the drug cost to the pharmacist 100%. So the pharmacist is paid and they're removed. And you just go and pick up your drugs when you need them, and you pay the carrier your monthly plan premium.
Yeah, so it's essentially letting you finance your meds on a
Correct.
very calculated, broken out monthly payment every month. And again, you're getting 0 interest-free financing terms from the insurance company.
And they cannot terminate your plan for non-payment.
Right.
They can terminate your payment plan, but not your plan.
Okay, so with all that, what would you do if you are a good broker, Brian, that's trying? What are we advising our agents or any agents listening to do?
Well, first of all, contact all of your clients now. Your MedSup clients, which will also be your PDP standalone clients.
Yep.
Contact them now. Let them know big changes are coming, because I guarantee they're not.
Send them that meme. The winter is coming. Brace yourselves.
Yeah.
Meme.
No, but to your point, though, I think it's important. Setting the right expectation is important, right? So I think that to your point, if you're calling your members and you're having a quick 2-minute conversation and just saying, hey, it's not your particular plan. Just so you know, this you're going to get your annual notice of change. You're going to see things changing this fall. I'm here for you. I can talk to you about options. We can go through it all, but just making you aware, you're probably going to see some more significant changes this upcoming year. We don't know what they are yet, but they're probably going to be more significant than in years past. I think that's important to kind of set the table.
But have a plan,
right?
Have a marketing plan, an access plan to your current book of business. Because other than that, if you don't, you're going to play safety and you're going to play defense all AEP, and you will not grow. When this is going to be the biggest annual election period we've ever seen for growth opportunities.
Yep. The other thing I would tell people too, and I try not to be too self-promoting, but it can be us, it can be any other FMO, but if you're an independent broker that's out there, you need to be educated. You need to understand exactly what's happening. You need to have an agency, an upline, an FMO. Pick your acronym of whatever you want to call people, but you need to have somebody who's guiding you through this and training and educating you on these changes that are happening so that you can go be effective and go be a professional. So if you don't have that, absolutely, I'll raise my hand. We train constantly on all these different topics and areas. We'd love to have you. We do boot camps all the time. Definitely educate yourself and become the actual knowledgeable professional so that you have value to your clients.
Absolutely.
And with all this, to that point, we are viewing all of the opportunity in all of this chaos, and we're planning right now. We're strategizing with the lead strategy, with where we're going to be marketing, with where we can pick up, where we can help more consumers, and we're very, very optimistic about having an awesome annual enrollment despite all of this chaos. So, we're kind of just telling you about all of the headwinds out there, and so you all can be educated as to what's going on and have these intelligent conversations with your customers, your consumers. And when you do get your clients reaching out, like Brian said, freaked out about their ANOX, you know how to explain things in an intelligent way. It's going to make sense to them.
Yeah. Dive in, learn all you can. Our podcast is a great source of truth, because I've been hearing nothing but, high level praise and thanks for the content that you guys put out. But obviously I wouldn't have known any of this information had I not been involved. And this is my 9 to 5. And I dive into this. I eat, sleep, and drink Medicare. So if you're not doing that, you're
And lastly, I would add to that, we'll put the link in the episode too, so that everybody has it. But we'll have some upcoming trainings for the Part D, Inflation Reduction Act. And so if you want to attend a training, it's likely going to be Brian doing them. That instead of this being a conversational kind of discussion about what's happening, probably a more formal and structured training on the Part D Inflation Reduction Act.
Yeah, to that point, I wouldn't claim this to be source of truth necessarily. In fact, I'd put a disclaimer out there and be like, hey, we're just roundtable discussing stuff off the cusp. And so if we're ever misspeaking or saying something, there's a lot of changes and topics and things going on. So we're trying to, give our context and our opinion on stuff.
Good catch there. That was verbatim from someone though.
But we are, like I said, trying not to have copious notes or PowerPoint presentations, more just having an informal discussion about how we think this matters to the industry, to our FMO partners, to agents, and ultimately to the consumers. But, if we ever misstep or misspeak, I know there's probably, we know there are agents that'll correct us in the comments on anything.
That's true. So, like everything, plan on, if you want training from us, definitely you'll have your opportunity. We don't care if you're one of our contracted line agents. We don't care if you're with some other, we don't care. We'll train you, we'll teach you. You can attend our trainings. We're happy to do it. That's what we do. So look for the link in the comments. Feel free to attend any of those trainings that we're offering up and making available to you. If you want to come out to any of our 2 or 3 day agent training boot camps, just let us know. We're happy to do that as well. And the last self-promoting part, we forgot to mention to like and subscribe and do all the things.
Click that button. I always want to do that.
To promote
click
our,
the button.
Yeah, supposedly 98% of our watchers and listeners are not subscribed to the channel on YouTube. So come on.
Can you add that in for me? Click the button.
Oh, he will.
He will add it in there.
This way?
Yeah, there you go.
All right, there we go.
All right, so it's probably enough for this week. We have just a couple preview. We have we'll probably be shooting a couple guests next week. I think you'll all be excited to hear from them. So just a little sneak preview for upcoming episodes. So a lot of great content coming your way. You know how to find us.
Agent Boost.